Okay, so what I wanted to talk about is largely TBI program that the group has worked on for well over a decade. TBI it was clearly, obviously going to be a problem after 2003 when U.S. sent a lot of troops overseas, and sorry, that's too. So at that time, fortunately, Ming Wang came to our Center of Excellence at the VA where I worked, and we began to talk about looking at TBI. And it continues to be an issue in terms of identification. It's somewhat of an invisible injury. Okay, let's see, there we go. In fact, let me just quickly say that recently, if you read New York Times, in addition to blast injuries, which are well known by now, there are overpressure waves from these big guns that people shoot. And if they're shot too often, they can cause injury. And there was an article about a group that was sent to Syria and had such a high tempo of using the guns that they are probably brain injured and complaining about it, but again, not having been brain scanned, they have not really been attended to, perhaps properly, and not because they've not been diagnosed. Some of them have been discharged from the military, perhaps improperly. Okay, so. I prepared this slide for some training I did recently overseas with some of the Ukrainian workers who were working with the troops from there. And basically, when we really became aware of TBI as a problem and its propensity to impact PTSD diagnosis was in 2014, and that was through the Marine Resiliency Study, which is a longitudinal study in which we were able to look pre-deployment and post-deployment at outcomes. And we show that mild TBI, particularly 1 second or more loss of consciousness, was increased the risk for PTSD. And that was replicated by another person in our department, Dr. Steen, in a very much larger study. Additionally, more recently, TBI has been shown to be a risk factor for a lot of other mental health disorders and problems. Substance abuse disorders, and there's accumulating evidence that mild TBI injury might impede recovery from PTSD, and I believe I've seen that in my clinic, and can confer higher risk for suicide, both directly as well as through the acquired mental health disorders that are comorbid with it. So, from a clinical point of view, I have found it impossible to easily distinguish between the two from any kind of diagnostic categorization. The symptoms are highly overlapping in terms of sleep difficulties, poor concentration, irritability, fatigue, depression, memory problems, headaches. And so whether somebody has PTSD, TBI, or both are virtually impossible to figure out clinically. And so I was, I've been so very happy to be in San Diego, where the team has been working on TBI diagnosis, and I could send the patients to Ming Wang in the group for MEG scans. Now, MEG does detect PTSD, and this slide is just to to show that at least, and this is gamma band, has very similar kind of outcomes that one would see with fMRI for PTSD, with hyperactivity in the limbic area, the amygdala area, and hypoactivity in the frontal cortex. The only differential with a MEG is a MEG identified at a few additional areas in the brain, being the lateral orbital frontal cortex and the precuneus, but generally very similar to fMRI findings. The problem is diagnosing TBI. It's really it's an invisible illness. Even right now, the U.S. military, it has implemented assessing symptoms, but the assessments are all by asking questions. There's no diagnostic measure that one can hang on to truly objectively diagnose TBI. The MRI and the CT are particularly low at being able to positively diagnose mild TBI. The MEG has a lot of advantages, and these were talked about earlier in the talk, so I won't repeat these here. So the next 3 slides will be some of the advances that I think have been made through the research that's been done by the team. Let me back up if I can. How do I do that? I just wanted to kind of point out, of course, there's Roland and Ming Swang, who are crucial for the team, but additionally, Sharon Nichols, who's I think in the audience, does the cognitive work for the study, and Deborah Harrington has done some of the analysis, and of course Anne-Marie and Ashley, who, as well as other folks who are doing the assessments currently, do a lot of work to move this work forward. I have overseen the psychiatric aspect. Now let's see. Okay, there we go. So, oopsie, back up again. All right. So in 2014, the paper came out that showed delta wave slowing, and this are MEG slow waves, which is delta wave as well as some 4 to 7 hertz theta wave, and it's in a rather a good-sized group of healthy controls and folks with TBI, both blast and non-blast TBI, and it's through this analysis of these data, Dr. Wong was able to show that the blast TBI, mild TBI group, the sensitivity was about 86, and the non-blast 83, very good sensitivity specificity in terms of distinguishing TBI from not. Okay, and what's very special about the MEG is the MEG is able to detect individual injury. The slow waves can be are seen in the part of the brain where the injury occurs, and that's different for each patient. And there's an earlier paper in which it was shown that somebody with somewhat more acute TBI, these waves were present when the symptoms were there and went away when the symptoms began to resolve. This is not something that's been able to be really shown in the MEG study or in the fMRI studies. The MEG studies in aggregate show that there's often, in a large group of people, more injury in the frontal part of the brain, but that's because often the blast waves comes from the front. And more recently, the resting state MEG source imaging showed gamma band hyperactivity in blast TBI versus controls. And this, I'm not going to go in detail through what's at the bottom of the slide, but this is particularly interesting because if one then looks at the animal research, one can begin to think about the physiology, and based on the animal research, there's likely some injury to the parva-albumin gamma interneurons. So there's a way to point toward thinking about what the injury is in the treatment. And this work is ongoing. The goal of the current project that's funded through the VA merit system is to really develop a diagnostic marker that would distinguish TBI from healthy, from PTSD, from combination PTSD TBI. And other potential, and additionally, Dr. Wong has a study in which there we go, which is, electrical stimulation study, and that's something that is under, I don't think the paper, there's one paper out that shows, and some early analysis that shows that the electrical stimulation may be a positive treatment for the TBI. Other future studies would be a potential use of MEG for a pre-post treatment measure, as well as to look at MEG as a marker and look at it in relation to blood-based biomarker. And we actually have blood through the marine resiliency study where at some point this might be able to be done. And this is the group and the funding.